Imagine trying to hydrate a parched desert by, well, intentionally setting it on fire.
Right. It sounds completely counterintuitive.
Impossible, even.
Mhm.
But, in the rapidly evolving world of modern bioengineering, clinicians are actually using tissue vaporizing lasers to do exactly that to the human body.
Yeah, it's a wild concept.
Welcome to the deep dive, everyone. We are looking at a huge stack of sources today that honestly totally upends how we think about tissue repair. We've got biomedical engineering papers on signal attenuation, clinical trials focused on fractional CO2 lasers, and some truly cutting-edge mathematical research on electrical tissue modeling.
And it is just a phenomenal collection of data because, well, it forces us to move past what we can see with our bare eyes.
Right, because normally healing is a very visual experience for you and me.
Exactly. A scab forms, the redness fades away, that sort of thing. But this research requires us to focus on what we can measure invisibly at the cellular level.
And that is the core mission for our deep dive today. We are unpacking a highly specific but incredibly revealing biological mystery. Namely, how does progressive mucosal rehydration across a laser treatment series alter real-time tissue bioimpedance measurements?
Which I know is undeniably a really dense academic premise.
Yeah, it is a total mouthful. Okay, let's unpack this, because underneath all that heavy terminology is a concept that's universally relevant to you.
Definitely.
We're basically going to decode the electrical language of healing tissue. We're exploring how doctors can quite literally intercept electrical signals to listen to your cells as they draw in water, remodel themselves, and heal over time.
Right, and to do that, we first have to understand the actual language the diagnostic machines are listening for in the first place.
The bioimpedance.
Exactly, bioimpedance. So before we even touch on heat-based lasers or mucosal healing, we need to establish the baseline of what happens when you introduce a tiny, entirely painless electrical current into the human body.
Because, biological tissue isn't just a simple copper wire.
No, not at all.
It doesn't conduct electricity perfectly, but it also doesn't completely block it either, right?
Yeah, it sits somewhere in the middle. It creates a highly complex environment. So the physical basis of this bioimpedance relies on two fundamental components in your tissue. You have resistors and you have capacitors.
Like, break that down for us.
Sure. Think of the physiological fluid, so the water mixed with electrolytes like sodium and potassium that surround and fill your cells.
Okay.
These fluids act as your body's resistors. They allow electrical current to pass through, but they offer a certain amount of resistance depending on, well, how much fluid is actually present and the concentration of those ions.
Got it. So the fluid pathways are the resistors, and the capacitors, on the other hand, those are the cell membranes themselves, right?
Correct. Cell membranes are constructed from a lipid bilayer. It's essentially a microscopic double layer of fat.
And fats are hydrophobic.
Exactly. They repel water, and crucially, they act as electrical insulators. So when an electrical current traveling through the body hits a cell membrane, the membrane momentarily halts and stores that electrical charge before releasing it.
Almost like a tiny battery.
Yeah, exactly like that.
Yeah.
That ability to store the charge is what we call capacitance.
Which basically makes the human body a walking, breathing, parallel electrical circuit.
Pretty much.
And what I found fascinating in the sources is how the frequency of the electrical current you introduce completely changes how the signal navigates that circuit. They heavily contrast low-frequency currents with high-frequency currents.
Right, because the frequency dictates the path of least resistance. So low-frequency currents, they simply do not possess the energy required to push past the insulative barrier of that lipid bilayer we just talked about.
The fat layer.
Yeah, the cell membranes act like a physical wall. Consequently, the low-frequency current is forced to travel around the cells. It moves exclusively through the extracellular fluid.
Moisture sitting in the spaces between your cells.
Exactly.
Okay, wait, let me try to visualize this to make sure we are mapping it out clearly for you listening, because I was thinking about this earlier.
Go for it.
Think of a low-frequency current, like a delivery driver who can only drive on the streets. The streets are the extracellular fluid. The driver has to navigate all around the buildings, the cells, to get through the city.
Okay, I like that.
But a high-frequency current operates differently. It's like a delivery driver who somehow has master keys and can just drive a truck straight through the lobbies of all the buildings.
That is actually a brilliant analogy, yes. The high-frequency current penetrates the cell membrane. Because it can travel freely through both the inside of the building and the outside streets, it measures the total fluid environment.
both intracellular and extracellular combined.
Right. So by sweeping a current across a tissue and measuring the bioimpedance at multiple frequencies, scientists can generate a highly detailed three-dimensional map of the tissue's underlying structure and cellular health.
And if we synthesize that map, the bottom line, like the golden rule we need to keep in mind as we move forward, is that water equals conductivity.
Emphatically, yes.
Because your physiological fluids are full of those conductive electrolytes, more tissue water equates to a lower resistance to the electrical current. We refer to that as lower impedance.
And conversely, less water, meaning dehydrated or atrophied tissue, results in higher resistance, higher impedance.
Okay, so more water is lower impedance, less water is higher impedance.
Yeah.
With that established, we run straight into the massive paradox in the clinical sources.
The fire in the desert.
Exactly. We are looking at therapies utilizing fractional CO2 lasers. Lasers emit intense, focused thermal energy. I mean, they literally burn organic material.
They do.
Yet the data demonstrates that clinicians use these heat-based lasers to aggressively hydrate mucosal tissue. How on earth does burning tissue increase its water content?
Well, we have to contextualize how these specific lasers are deployed. The sources focus heavily on a widespread condition known as genitourinary syndrome of menopause, or GSM.
Right. And the clinical presentation of GSM involves severe tissue dryness, chronic irritation, microscopic tearing, and a pretty profound loss of elasticity.
Yeah.
It all stems from systemic hypoestrogenism, which is a significant drop in estrogen levels.
Right. When estrogen levels decline, the mucosal tissue in the genitourinary tract undergoes atrophy. The epithelial layer thins out dramatically, it loses its natural lubrication mechanisms, and the underlying connective tissue architecture just sort of deteriorates.
Which sounds incredibly painful.
It is. And for decades, the gold standard treatment has been localized estrogen therapy. However, many women seek non-hormonal options. This could be due to medical contraindications, like an estrogen receptor-positive breast cancer history, or, honestly, simply personal preference.
Enter the fractional CO2 laser. But again, a laser is delivering thermal damage.
Yeah. What's fascinating here is the mechanism hinges on how the body's evolutionary repair systems respond to a highly controlled, specific type of thermal energy.
Right, because it's not just a blue torch.
Exactly. The laser doesn't indiscriminately scorch a wide area of tissue. The term fractional means the device splits the laser beam into tiny individual shafts of light.
Like a microscopic grid of heat.
Yes. It creates microscopic columns of thermal injury, which the sources call microablative zones, deep into the epithelium and the lamina propria below it, while leaving all the surrounding tissue completely intact.
And so the body detects these microscopic thermal injuries and basically treats them as a massive emergency. It triggers a profound wound healing cascade.
Precisely. The thermal damage instantly denatures the old degraded collagen fibers that were causing the tissue to lose elasticity in the first place.
Out with the old.
Right. But more importantly, the heat shock proteins released by those damaged cells send a signal to local fibroblasts.
And those are like the biological factories in your connective tissue, right?
Exactly. They kick into overdrive. They begin rapidly synthesizing brand new collagen and elastin fibers.
The sources outline a few distinct phases of this renewal. I notice we see neoangiogenesis, which is the sprouting of new microscopic blood vessels to feed the recovering area. And we also see a significant increase in the synthesis of intracellular glycogen.
Yeah, and the key to the hydration paradox we were talking about really lies in the extracellular matrix. As the fibroblasts repair those thermal columns, they pump the surrounding tissue full of glycosaminoglycans.
Okay, that is a word.
I know, it's a big one. The most famous of which is hyaluronic acid. You've probably heard of it in skincare.
Oh yeah, definitely. And these molecules are incredibly hydrophilic.
They are.
They are intensely water-loving molecules.
They basically function as biological sponges. These molecules have a strong negative electrical charge, which aggressively attracts water dipoles from the new blood vessels created during that neoangiogenesis phase.
Wow.
So by rebuilding this ground substance of the connective tissue with these negatively charged sponges, the tissue's permeability completely shifts. It actively draws in and traps moisture from the surrounding circulatory system.
So the long-term result of the thermal burn is a structurally thicker, drastically more hydrated mucosa.
Yeah. It is a brilliant hack of the human body.
You are basically weaponizing a controlled injury to force the tissue to completely remodel its own cellular matrix substituting a non-hormonal trigger for an estrogenic one.
It's regenerative medicine at its most elegant, honestly.
But, okay, here's where it gets really interesting. Because there's a temporal contradiction here.
Okay, what do you mean?
We know the long-term downstream effect of the laser therapy is profound hydration. And our golden rule of bioimpedance is that more water equals lower electrical resistance.
Right.
So what happens to the electrical measurements during the actual laser zap? I mean, wouldn't blasting tissue with a laser instantly vaporize the water, temporarily doing the exact opposite of hydrating it?
It does. You're completely right. The localized environment undergoes extreme instantaneous desiccation.
It dries out.
Massively. When we look at the optical and thermal monitoring sources detailing the acute phase, so the exact milliseconds, the laser or radio frequency energy is delivered, the tissue water literally hits its boiling point.
It undergoes a phase change. Liquid water turns into gas.
Yes, and the rapid expansion of this gas creates what the researchers term steam domains inside those microscopic columns.
Steam domains.
Yeah. Now think about our electrical circuit. If physiological fluid rich in electrolytes is our body's primary electrical conductor, steam represents the exact opposite.
Right. Steam is a terrible conductor. It's basically air.
It is an insulative void. So during that acute phase, because of this rapid desiccation and the proliferation of non-conductive steam domains, the real-time bioimpedance measurements register a severe, violent spike.
Because the electrical current is suddenly attempting to travel through a matrix of dehydrated tissue in gaseous pockets, so the resistance just skyrockets. So the immediate second-by-second readout is a massive spike in impedance. The tissue is acutely dry. But then, as the days and weeks pass following the session, the biological repair mechanisms take over. We transition into the progressive phase.
Right, and one of the detailed studies tracked this progressive phase using a 635 nanometer diode laser model for wound healing. They placed electrodes and measured the tissue's bioimpedance on days 3, 7, 10, and 14 after the initial thermal injury.
So they were tracking the exact timeline of those molecular sponges going to work.
Yes.
As the days pass, the neoangiogenesis restores blood flow, the fibroblasts synthesize the hydrophilic molecules, and the tissue begins to swell with trapped moisture. And the electrical circuits allow researchers to track this without having to constantly biopsy the tissue, which is amazing for the patient.
It's a huge leap forward. Based on accepted circuit models of human body hydration, as the volume of physiological fluid in the interstitial spaces increases, the overall impedance of the body fluid decreases.
Lower resistance.
Exactly. In the specific language of the engineering sources, this increased conductivity is recorded as a decrease in signal attenuation.
Okay, let's define signal attenuation for the listener real quick. It essentially means how much of the electrical signal is weakened or diluted or absorbed as it travels from point A to point B, right?
That's spot on. A stronger signal makes it to the receiving electrode because there is an abundance of fluid acting as a low-resistance highway. But what's crucial here is how they measure this attenuation.
Right.
The sources note the hydration rate in decibels per minute.
Which might sound super strange to anyone listening. Usually when we hear decibels, we think of sound volume, like a jet engine or a rock concert. Why on earth are bioengineers using an acoustic measurement to track cellular water?
It's a great question. Decibels are actually a universal unit of measurement used in engineering to express the ratio of two values of a physical quantity, often power or intensity. It's a logarithmic scale.
Not a linear one.
Right. Biological tissue resistance compounds as current travels through multiple layers of cells, fascia, and fluid. The signal loss isn't perfectly linear. So using a logarithmic scale like decibels allows engineers to accurately plot the vast compounding changes in electrical signal strength as the tissue remodels.
So if you are a doctor measuring a patient's mucosal tissue over the course of a laser series, say maybe 3 sessions spaced 4 weeks apart, you will see the baseline impedance measured in this logarithmic scale steadily drop week after week.
Yes. It replaces subjective questioning with hard mathematical data. You don't have to rely solely on asking a patient to rate their discomfort on a scale of 1 to 10, or, visually guessing if the tissue looks plumper.
Right.
You can just analyze the electrical readout and objectively verify that the extracellular matrix is retaining a higher volume of water today than it was 30 days ago.
Which is incredible, but it introduces a massive biological variable.
Oh, definitely.
Because human biology is notoriously messy. We are not manufactured on an assembly line.
No, we are not.
If a clinician is tracking this progressive drop in impedance, does every patient's electrical baseline shift at the same velocity? I mean, if two patients receive the exact same fractional laser treatment at the exact same energy settings, do their tissues hydrate at the same rate?
The clinical data emphatically says no. And
Okay.
this variability is why the research repository data from Victoria University is so critical to the real-world application of this technology.
Right. They developed a mathematical model to decode why mucosal hydration rates differ so wildly between individuals.
They did. The researchers isolated two primary mathematical variables that govern this rate of tissue hydration.
Wow.
The first is a time-dependent characteristic factor deeply tied to a patient's baseline metabolic rate, which they represent with the Greek letter tau.
Tau. Okay.
And the second variable is the muscle-to-fat ratio of the individual patient, represented by the Greek letter theta. In the context of their modeling, theta serves as a mathematical surrogate for body mass index, or BMI.
Okay, wait. I have to push back on this premise just a little bit. Because BMI is a notoriously flawed metric in the broader medical community. It's just a simple calculation of weight divided by height squared. It completely fails to differentiate between bone density, muscle mass, or body fat.
That's true.
Like a professional athlete with incredibly low body fat can have the exact same BMI as someone who is clinically obese. So why does the electrical signal or the tissue's hydration rate care about a generalized metric like BMI?
That is a very valid critique of BMI as a standalone health metric. Absolutely. However, in the context of this specific bioimpedance model, the theta variable is primarily tracking the ratio of adipose tissue, which is fat, to lean muscle mass, using BMI as basically an accessible clinical proxy.
Okay, so it's a proxy.
Right. And the reason the electrical current cares is because adipose tissue and muscle tissue handle water completely differently.
Because fat is hydrophobic.
Precisely. Adipose tissue has a significantly lower water content than lean muscle. It also has a totally different vascular structure. If a patient has a high volume of adipose tissue altering their overall body composition, it fundamentally shifts their baseline systemic conductivity.
That makes sense.
Furthermore, varying body compositions are often linked to different basal metabolic rates, which directly influences that first variable, tau.
So the actual metabolic engine driving the tissue repair is running at a totally different speed.
Exactly. The researchers broke down the specific interactions. Individuals with a lower BMI, which translates in their math to a higher theta ratio of lean tissue to fat, they exhibit a remarkably lower tau. Their time-dependent factor is compressed.
Meaning their metabolic and cellular repair mechanisms process that thermal injury much faster.
Yeah, and the empirical data proves it out. The study tracked an individual with a BMI of 22.7. When interrogating their tissue at high frequencies of 800 kilohertz and 1 megahertz, so frequencies high enough to penetrate the cell membranes.
The master keys to the building.
Yes. The subject demonstrated a hydration rate of 0.6 to 0.7 decibels per minute. In the realm of electrical tissue remodeling, that is a robust, incredibly rapid change in signal attenuation. The tissue was flooding with water quickly.
Wow. And when they modeled individuals on the other end of the spectrum?
Subjects with a higher BMI, such as an individual they tracked with a BMI of 41.2, exhibited a significantly elongated tau. Their time factor stretched out.
Okay.
For these individuals, the bioimpedance data revealed almost a flat line in the short term. The progressive hydration rate was drastically slower, reflecting the different vascularization and fluid dynamics of their specific tissue composition.
That is so interesting. So if you're listening to this and wondering why your doctor is asking a barrage of questions about your metabolism, body composition, or weight, before scheduling a localized laser treatment, this physics model is exactly why.
Yes.
You cannot apply a one-size-fits-all treatment protocol.
Exactly. The real-time impedance readings are dynamically linked not just to the wattage of the laser, but to the physiological blueprint of the specific patient sitting in the chair.
And it's not just systemic stuff, right? The clinical sources also caution that environmental surface factors, like the natural presence of cervical fluids, varying levels of saliva, or even the microscopic angle of how the electrode contacts the mucosa, can acutely alter the readings.
Yes, the electrode-tissue interface is hypersensitive.
So if we connect this to the bigger picture.
When you combine the environmental sensitivity with the metabolic variables of tau and theta, it points to a massive paradigm shift.
Right.
We are looking at the foundational architecture of ultra-personalized medicine.
Meaning clinicians can completely discard the guesswork. Instead of a standardized protocol that says, every patient gets exactly 3 treatments spaced 4 weeks apart, the therapy becomes entirely feedback-driven.
Right. By utilizing real-time electrical data and factoring in the mathematical models of the patient's unique metabolic rate and body composition, a doctor can pinpoint the exact moment a patient's mucosal tissue has achieved maximum hydration.
It's precision medicine.
Completely. They establish mathematical thresholds that indicate the cellular remodeling is complete, tailoring the endpoint of the therapy specifically to the individual's biological timeline.
This is wild. So to recap our deep dive today, we started by looking at the baseline physics of the human body, how our interstitial fluids act as electrical resistors, and our lipid cell membranes function as capacitors.
Right.
Then we explored the paradox of how controlled microscopic thermal burns trigger a wound-healing cascade that floods the connective tissue with hydrophilic sponges, ultimately hydrating parched tissue.
We observed the electrical roller coaster of that process, too. The acute, highly resistant steam domains giving way to progressive, highly conductive rehydration.
And finally, we broke down how the specific variables of human metabolism and body composition drastically alter the speed of that biological repair, which requires us to measure signal attenuation in real time. It just completely reframes the relationship between the machines we build and the tissue we are trying to heal.
It really does. It forces the technology to adapt to the patient rather than hoping the patient adapts to the technology.
Which brings up a final provocative thought, something for you to consider long after this deep dive wraps up.
Oh, I like these.
We've established that clinicians can use electrical impedance to passively listen to mucosal tissue as it heals and draws in moisture. The electrodes are basically acting as a microphone for the cellular environment.
Right, we're intercepting the tissue's status reports.
But the field of bioelectronics is advancing at lightning speed. If we can build algorithms that understand this electrical language perfectly, could we reverse engineer the process? Imagine a localized, implantable, wearable device that rests against the mucosa. It just sits there, running low and high-frequency currents, passively monitoring the tissue's bioimpedance 24/7.
A continuous diagnostic loop.
Exactly. And the very second it detects a minute, microscopic spike in impedance, a tiny loss of conductivity that signals the absolute earliest stages of cellular dehydration, long before the tissue atrophies or the patient ever feels a symptom. The device doesn't just log the data, it responds.
Okay, I see where you're going with this.
It automatically emits a targeted, proprietary electrical microfrequency that commands the local fibroblasts to synthesize hyaluronic acid and hydrate the tissue.
You are describing a closed-loop bioelectronic therapeutic system.
Exactly.
It bypasses the need for a thermal laser burn entirely. It detects the initial biological failure and triggers the regenerative mechanisms before the microscopic damage can even cascade into a clinical condition.
Instead of just listening to the cells complain that they are dry, the technology starts talking back, commanding them to stay hydrated. We move from responsive medicine to active biological maintenance.
You know, based on the foundational engineering and cellular logic we have reviewed today, a closed-loop system like that is entirely plausible. We already have the vocabulary. It is just a matter of building the speaker.
The electrical language of healing is getting louder. Thank you for joining us on this deep dive into bioimpedance and tissue hydration. Keep questioning the hidden mechanisms of the human body, and remember, the most profound biological changes are often the ones you will never see.